Thank you for tuning into Orthopedia for a discussion on the biomechanics of the knee as they relate to anterior cruciate ligament, or ACL, tears. The ACL is a ligamentous structure comprised of parallel fibers of collagen and fibroblasts. The ACL attaches proximally to the posterior medial portion of the lateral femoral condyle. It attaches distally on the anterior portion of the tibia's intercondylar fossa and crosses the interarticular space. The ACL restricts anterior motion of the tibia in relation to the femur and resists tibiomedial and lateral rotation, in addition to providing limited resistance to varus and valgus stresses. Together, the ACL and posterior cruciate ligament, or PCL, limit anterior to posterior joint translation and internal and external rotation while still allowing for flexion and extension with restraint only at the extremes of normal range of motion. The ACL is the primary ligament responsible for anterior translational restraint of the tibia. It does this throughout flexion and extension of the knee. The anterior medial bundle attaches on the medial wall of the lateral femoral condyle. The posterior lateral bundle is just distal and posterior. When the knee is in full extension, the AM and PL bundles both align vertically. However, as the knee is brought into flexion, the bundles cross over one another into a more horizontal position. This is due to the orientation of the femoral attachments. ACL tears are the most common cause of traumatic hemarthrosis of the knee and account for over 60% of all knee injuries that occur during planting and pivoting sports. Historically, these injuries are more common in women than men, with some studies publishing rates as high as 3 times that of the male sports playing population of the same age. But NCAA surveillance data also confirms that American football accounts for more of these injuries than other sports. From an anatomic perspective, there are multiple factors that contribute to this disparity, including larger Q angles in women, ligamentous laxity secondary to hormonal variation, and variation in the size and shape of the intercondylar notch. A narrower notch may result in a predisposition for ACL tears. Before Claudius Galen's description of the ACL as a knee stabilizer in Roman times, it was thought to be a part of the nervous system. Slowly over time, the understanding of its function improved, and the technique to test its function, a Lachmann's test, was named in 1875. Around the same time, Paul Sagan described an avulsion fracture of the anterolateral margin of the tibial plateau that is now considered pathognomonic for ACL rupture. At the time, researchers didn't realize the presence of a ligament on the lateral side of the knee, which has since been identified as the anterolateral ligament. The anterolateral ligament, or ALL, is part of the anterolateral complex of the knee, which provides additional rotational stability. In an ACL tear, the rotational component of the mechanism of injury is thought to result in an avulsion of the anterolateral ligament from its point of attachment on the tibia. This is seen on X-ray as a Sagan fracture. Non-contact ACL injuries commonly occur in one of 3 ways. First, through high-energy, high-speed, non-contact athletic activity that involves a plant and pivot motion to rapidly change direction. Second, a jump and landing that causes valgus collapse of the knee. And third, a low-energy, low-speed fall that involves a twisting motion and that occurs when the center of mass is behind the tibia. Contact and polytrauma injuries can also involve the ACL, though they're less frequent and usually involve direct impact with the lower extremity while the leg is under load. Contact can result in a knee-in, toe-out position, in which the knee is in valgus and the ankle is in eversion while the leg is under load. Contact injuries can also occur with the same knee-out, toe-in alignment, in which the knee is under varus and the foot is in abduction while under load. In these cases, the joint is hyperextended and under load at the same time. These positions increase the likelihood of ACL injury when the leg under load is impacted. Initial patient complaints almost always include swelling and pain of the knee due to the disruption of the ACL's vascular supply. Given the body's ability to essentially splint itself through swelling, it is not surprising that instability, which is the sensation of the knee giving way, is typically short-lived as the initial complaint and may fade until swelling has resolved. Following reduction of the initial swelling, instability during plant and pivot motions is common. An initial physical exam should include Lockman or pivot shift tests, though neither is fully reliable during the acute phase due to swelling and significant patient discomfort with associated guarding. A neurovascular evaluation is important, particularly if there's concern of knee dislocation in the setting of a multiligamentous injury or significant trauma. When the patient's condition allows, conduct a re-examination to evaluate and grade the instability of the ACL and other supporting ligaments of the knee, specifically the medial collateral ligament. There is also risk of associated posterior lateral corner injuries. During initial evaluation, plain AP, lateral, and merchant view x-rays of the knee will help rule out any associated fractures. During radiographic review, pay careful attention to ruling out an avulsion fracture of the tibial spine and a pathognomonic Sagan fracture. Obtain MRI to confirm the ACL injury, evaluate the menisci and other stabilizing ligaments of the knee, and further evaluate the cartilage and bony anatomy. ACL ruptures are classified into 3 different grades. In grade 1 injuries, the ACL is stretched, there is little to no pain or swelling, and there is no increased laxity or sensation of instability. The ligament is considered functionally intact. Grade 2 injuries are partial or incomplete tears of the ACL. There is typically a hemarthrosis, though swelling is just moderate, and the patient will experience only mild to moderate tenderness. There may be an increase in laxity with Lockman, anterior drawer, or pivot shift testing. There should still be a defined endpoint to the ligament, however. Grade 3 injuries are complete ruptures. Significant initial pain may resolve quickly. There is typically significant swelling and no clear endpoint with Lockman and anterior drawer testing. The Sherman classification can also be applied to help further quantify the location of the ACL tear or disruption. Type 1 tears are disruptions at the ACL's femoral attachment point. Type 2 tears are close to the femoral wall, but a remnant of the ligament remains attached to the femur. Type 3 tears are located roughly 1/3 of the way down the ligament when measuring from proximal to distal. Type 4 tears are located mid-substance in the ligament. When considering surgical intervention, discuss with the patient their activity levels prior to injury and their intended postoperative activity levels. Older patients with sedentary lifestyles and even active patients who do not participate in activities requiring plant and pivot motions may be able to use a brace for stability, non-operative management with quadriceps strengthening, and work to restore normal knee range of motion. Keep in mind that in all patient populations, reconstruction prevents recurrent instability and repetitive injury to the menisci and articular surfaces of the knee. Failure to address this instability and the resulting recurrent injury to the other structures of the knee has been shown to accelerate wear of the articular surfaces and can lead to a more rapid advancement of osteoarthritis. Athletes and active patients should consider surgical intervention for the best chance at successfully returning to sport, particularly those who participate in jumping sports or sports where plant and pivot maneuvers are likely. With reconstruction and appropriate physical therapy, most patients will successfully return to their sport and pre-injury level of play. Most patients who undergo ACL reconstruction will require 6 to 8 months of activity restriction and physical therapy, with an additional 3 to 4 months of conditioning before they feel fully recovered. Return to play is a heavily discussed topic. Patients can typically return after a return to play assessment to assure they have adequate strength in the quadriceps group to protect the reconstruction. ACL injury prevention programs are also important to mention, as they have a significant protective effect and can reduce injury rates up to 53%. Operative intervention depends on the individual patient, surgeon, and injury. Surgical options include repair with internal brace augmentation or reconstruction. By the early 1900s, multiple surgeons reported various knee stabilizing procedures using autologous fascia lata or meniscal grafts. By the 1930s, grafts we commonly use today were available, including hamstring autografts and patellar tendon grafts. In the 1960s and 70s, surgeons explored using bone patellar tendon bone and synthetic grafts with varying success. Current reconstruction procedures and grafts come from this diverse history, though even today we continue to explore options for improved ACL reconstruction and repair outcomes. Today, reconstruction can be completed with a choice of grafts. These include grafts from both autograft and allograft tissue, all soft tissue grafts, or a combination of soft tissue and osseous or bone block grafts. A coordinated discussion between surgeon and patient can inform the decision on graft choice.